My name is Sarah Breckville, and today I will be serving as your program facilitator. I will help present your questions to our panel of OBGYN physicians and midwives if you are thinking about becoming pregnant or are newly pregnant. They will answer all of your pregnancy questions and share resources available to support you from bump to birth. So today we are joined by four panelists: Dr. Kenneth Cavone, Chief of OBGYN at Jefferson Health, New Jersey; Vicki Astaraziga, Midwifery Obstetrics at Jefferson Health, New Jersey; Dr. Jennifer Hummel, Medical Director, Obstetrics and Gynecology at Jefferson Health, New Jersey; and finally, Jessica Hayes, Obstetrics Midwifery at Jefferson Health, New Jersey. Well, thank you so much for submitting your questions in advance. And if you have any questions throughout the discussion tonight, for those joining us on their computer or tablet, at the bottom of your screen, you should see an icon that says Q&A. If you don't see it, maybe just try moving your mouse around a bit and it should appear. But go ahead and please select on that Q&A icon and you can enter your question right there in the text box. Since this is a sensitive topic, when you submit your questions, you have the option to submit anonymously. And for those joining us by telephone, if able, please go ahead and email any of your questions to marketingevents@jefferson.edu. And we'll do our very best to get to as many questions as possible, but may not be able to answer all of them during tonight's virtual event. And of course, due to hospital university guidelines and privacy, we are unable to comment on specific cases or the number of patients we have treated or are currently treating. Likewise, if you are experiencing any symptoms that may require medical attention, please consult a medical professional. Finally, don't worry, we've taken the liberty of muting everyone's line to eliminate that annoying background noise, so feel free to move around and get comfortable. So with that, I want to give each of our physicians a minute to say hello, and then we'll move into our submitted questions for the evening. So Dr. Hummel, we'll start with you. How are you doing this evening?
I'm doing well, Sarah. Thanks. Thank you all for joining tonight's webinar. I'm happy to be here with my Jefferson Health, New Jersey colleagues. This is a great opportunity to talk about planning for your pregnancy, and I'm looking forward to the conversation tonight.
Okay, great. Well, thank you so much, Dr. Hummel. All right, and we'll turn over to Vicki. Welcome, Vicki. How are you doing this evening?
I'm doing well as well. I'm excited about tonight and get some conversation started.
Awesome, sounds good. Okay, Dr. Cavone, how are you doing?
I'm doing very well, Sarah. Thanks for the introduction. And thank you, everybody, for joining us on this webinar. We're looking forward to speaking to everybody. So.
Definitely. And Jessica, last but not least, welcome. Thanks for joining us.
Thank you for having me. I'm very excited. Love to be a part of this conversation. It's very important to many women that we serve in the community, and we're excited to talk about the topics.
Absolutely. Okay, well, let's dive into it. Without further ado, we'll go ahead and jump into the questions that were submitted this evening. So Dr. Cavone, let's go ahead and start with you. All right, question for you. When is it the appropriate time to set up a genetic health evaluation, before or during the pregnancy process?
Thanks, Sarah. So that's an excellent question. So actually, you can actually set up that evaluation before pregnancy as well as during pregnancy. So as your obstetrician, it's recommended by ACOG, which is the American College of Obstetricians and Gynecologists, that all patients be recommended to have genetic screening. Again, we offered prior to pregnancy and during pregnancy. Now, what we can offer prior to pregnancy is what's called carrier testing. So again, ACOG recommends that all patients be offered. Again, these are voluntarily tests, but be offered what's called carrier testing genetics. So carrier testing basically means it's used to help screen women who are asymptomatic to see if they have a specific gene mutation that might cause a particular disorder down the road. These are all blood tests. There's a wide variety of different carrier testing out there. Common ones that we screen for are things like cystic fibrosis, Tay-Sachs disease. Before we used to only screen patients based on their ethnic background. For example, if a patient was an Ashkenazi Jew, we would usually screen them for Tay-Sachs. However, due to the increased technology nowadays and the decreasing cost of these tests and the ability to do multiple tests in one blood draw, which is makes it so much easier for patients, we're able to do multiple tests at one time. So now we do what's called we do expanded genetic carrier testing. We don't just look at just your ethnic background. We offer all tests to all patients. Now, the reason why we recommend doing that pre-pregnancy is that if a patient is found to be a carrier of a certain genetic abnormality, the next step is to screen your partner, because it takes two basically to tango when it comes to an abnormality. So, if a patient is screened and is positive for a particular abnormality, and you screen the partner and they're also positive, then a patient and her partner have to decide what they want to do with these results. Do they want to conceive based on the fact that there's a potential increased risk of having a baby with an abnormality, or do they want to attempt other ways of getting pregnant, with either through reproductive technologies, such as pre-implanted genetics, which can be done through a reproductive endocrinologist, or do they want to use donor eggs? So that's the importance of getting screened prior to your pregnancy. Now, sometimes women, it's completely appropriate to be screened during your pregnancy. These same carrier testing can be done during your pregnancy as well. And again, the important thing of knowing the carrier status of a patient during a pregnancy, and knowing that if they potentially have a fetus that potentially has an abnormality, is that it helps kind of dictate how their care is going to be, dictate how their pregnancy is going to be, and also helps kind of determine what may happen afterwards, depending on what the abnormality is. So again, when it comes to genetic health evaluations, we are encouraged coming in prior to discuss this with your obstetrician, but we also encourage doing it during the pregnancy. And again, you can have a very open conversation with your obstetrician and gynecologist or your midwife about this. And if they feel like a more in-depth conversation has to be had, we are very good at sending our patients to meet with genetic counselors to discuss these testings and the results after they're done. So.
Okay, great. Thank you so much. Some really helpful information there. So thanks so much for taking the time to go through that. All right, moving along, Dr. Hummel, we'll have the next question for you. So a question from the audience: what are some red flags to look out for in all stages of pregnancy?
So there are definitely some things to look out for and be aware of throughout your pregnancy. Not all signs are of something bad, but they should definitely make you take notice. So for example, bleeding. We never say that bleeding is normal in pregnancy, but there are times where you might see some bleeding and it might not always be a big time of concern. So for example, spotting may be seen early when the embryo implants onto the lining of the uterus. And this usually happens at the time that you'll be due for a period. So it is typically just spotting, nothing to be concerned about. It is also common, especially in the first trimester, to get some bleeding behind the placenta. This is called a subchorionic hemorrhage. And it can be scary. You may bleed heavy like a period, but it's usually self-limiting, kind of walls itself off and doesn't cause problems with the pregnancy. However, bleeding like a period can also be a sign of a miscarriage, and typically it comes with bad cramping. So if you ever have those symptoms, it's definitely something to call your provider and to get evaluated to see if the pregnancy is still viable. Another time that you might get some bleeding in pregnancy is sometimes during intercourse. The cervix has a lot of extra blood flow to it. So anything disrupting the cervix can cause some spotting. And again, nothing to be concerned about. Another red flag could be cramping. This can, again, be very common in the early first trimester as the uterus is growing and expanding. The patient usually feels it as cramping. However, if you have bad cramping, especially if it is with bleeding, it could be a sign of a miscarriage and something to call us about. Also in the first trimester, if you have severe pain that's on one side or the other in the lower pelvis, it could be a sign of an ectopic where the pregnancy can be implanted in the fallopian tube. This can also be accompanied by vaginal bleeding, but it should definitely be evaluated immediately to rule out an ectopic pregnancy. And then as you go further in your pregnancy, especially in the third trimester, if the baby isn't moving well, we will talk about kick counts during your pregnancy. And if the fetus isn't moving that well, we definitely need to know about it. Also, if you get severe headaches that are not relieved by Tylenol, then we should definitely make sure that we check your blood pressure, because this could be a sign of preeclampsia, which is high blood pressure in pregnancy that can affect the kidneys and the liver and the pregnancy. And then any type of contractions that are happening regularly before term, which is 37 weeks of the pregnancy, we want to make sure that you're not in any kind of preterm labor. So definitely something to notify us about.
Okay, well, thank you. That was incredibly helpful. And I think just some good red flags to look out for, and so people can be educated throughout their pregnancy. So thank you. All right, so Vicki, now we'll go to you. A question from the audience. Many were actually wondering how to deal with anxiety during pregnancy, as well as how to stay active. So are there any certain exercises to avoid, or maybe some that are better than others?
First, I'd just like to acknowledge that so many people struggle with mood disorders, and this can include anxiety, depression, bipolar disorder, OCD. It's really important to talk to your provider, discuss how you're feeling. These type of conversations are just as important as any physical concerns that you might have. Second, ideally, this is something that we could talk about at a preconception visit to kind of prepare for things. Pregnancy is a time where you don't have a lot of control over your body, over your feelings, your emotions. So it's this total loss of control can, along with all the hormonal fluctuations of pregnancy, can really exacerbate any pre-existing mood disorders or bring to light, some new concerns. One way to cope with anxiety, or most mood disorders really, is just to talk. Talk to your provider, talk to a therapist or a counselor, your family, your support network or your village. It's just really important through life, especially, pregnancy and the postpartum period. And then again, your providers, be open and honest. We're here for you. That's one of, our jobs is just to kind of listen and kind of guide and give options of different things that, we can do. So many people are afraid to speak up because of social stigmas or concerns regarding labels, but it's just being open and honest with your providers is the biggest thing. Counseling and therapy can provide you with the tools that you need to cope with a lot of the feelings that we have. Establishing a relationship with a therapist, even if you don't already have one, is probably really important early on. Just because a lot of the practices, especially nowadays, have a long wait list. And if everything goes perfect and you don't need them, wonderful. But if it's hard to, if you're already starting behind the 8 ball, it's hard to kind of cope until you can get into a visit with them. Other options to cope with mood disorders can range anywhere from, vitamins and herbal supplements. Light therapy can make a big difference, massage, relaxation, and then prescription medicines. There's a lot of medications that we can prescribe in pregnancy that we feel safer than the alternative. So we know that untreated or even undertreated mood disorders in pregnancy can be harmful not only to the patient, but to the baby as well. And exercise, the second question, is a really great way to deal with mood disorders. And, for generally physically healthy pregnancy, it's important to stay active throughout the whole pregnancy. When we talk about exercise as a general rule, you can continue whatever you were doing before pregnancy. If your body is used to doing it, most often you can continue to do that. Some modifications might have to be made as far as, maybe shortening the duration or the intensity, just to kind of until your body gets used to the new physical changes with pregnancy. But some of the exceptions are anything that could involve potential abdominal trauma. So things like horseback riding or skiing, kickboxing, things like that. Yoga in particular is really, really good. It's actually been studied in pregnancy, and it's been known to help mental health and get you ready for birth and just kind of keep you all over active during the pregnancy. Let's see. If you don't exercise at all and you want to start something when you get pregnant, and that is fine too. Walking is a great way to start your exercise journey. It's recommended to have at least brisk activity for about 30 minutes a day, 5 days a week. But the most important thing is just to stay active. Start off slow and gradually increase your activity until, your tolerance, and increase your tolerance until you can reach your goals.
Okay, perfect. Thank you so much. And I think that was really helpful for a lot of our audience members tonight, just because we were receiving a lot of questions about exercise. So just knowing that you can continue that based on, what you've been doing yourself is, I think, probably really reassuring to hear, and knowing you could potentially even start. So thank you for detailing that for us. Okay, Jessica, let's turn to you now. We have a question from an attendee with a personal scenario that I'll read to you. So how important is it prenatal before conceiving? I have been taking mine, but often miss a few days.
Thank you, Sarah. This is a really great question. Prenatal vitamins are best started about 3 to 6 months before you try to conceive, with the latest being at least 1 month before conception. This is because the folic acid or folate that is necessary for the baby's brain and spinal cord needs to be in your body at the very beginning. So when this is forming, most people don't even know that they are pregnant. To answer the question, the second part of the question, it is okay to miss a few days. We are only human, but trying your best to take your vitamins is very important. If you're also taking a regular multivitamin, which most of them, especially for women, have at least the minimum amount of folic acid, 400 micrograms, then you should be covered. But of course, a prenatal is best. Just to clarify, folate is the natural form of folic acid. So you could see either of those on the back of your vitamins. And it's the folate is found in food. So leafy green vegetables, broccoli, Brussels sprouts, spinach, all of those foods have folate in it. So of course, there is some benefit to having those foods in your diet. And prenatal vitamins also contain important things like DHA, which is an omega-3 fatty acid, vitamin D, and sometimes iron. So all of those things are important and good for starting to make the baby.
Okay, thank you so much. And Jessica, I think your sound might be a little bit muffled, so not sure if there's anything you can do on your end just during
Talk
this.
louder.
Yeah, there you go. It's a little better. Okay, perfect. We'll move along now. All right, we'll turn to you, Dr. Cavone. All right, so a popular question about morning sickness. So here we go. What are some natural remedies for morning sickness?
Thanks, Sarah. So this is a question that's near and dear to my heart. When my wife was pregnant with all 3 of our children, she actually experienced morning sickness, unfortunately, for all 9 months of her pregnancy. So as a husband and as a provider, I know this well. So fortunate for most women, morning sickness does resolve on its own. About 90% of pregnant patients will experience morning sickness, and it's kind of a misnomer because morning sickness, even though there's a belief that morning sickness only happens in the morning, patients who've been pregnant before know that morning sickness can happen anytime during the day. Unfortunately, we don't know much about morning sickness as far as why it happens. There's a couple of theories, but nothing really concrete. That's why treating can be a bit difficult for the providers as well as the patients. So, but again, one good thing about morning sickness, it does usually resolve after the first trimester. So what things can you do? What do I counsel my patients when they come in for the first visit and say, listen, I'm throwing up, I feel nauseous, what can I do? First thing, before you get pregnant, it's kind of piggyback to what Jessica said, taking a prenatal vitamin. There's some good literature that says if you start taking your prenatal vitamin a month or 2 prior to conceiving, that might decrease your morning sickness. Also, for information for women who think, are they going to get sick when they're pregnant? Women that seem to get nauseous when they take birth, if they're on birth control pills, if they get nauseous while taking birth control pills, women who have a history of migraines, or women who get easily motion sickness, they may be at risk for morning sickness when they get pregnant. So again, first thing, make sure you're taking a vitamin prior to getting pregnant. That should help. But unfortunately, sometimes that doesn't help. So what can we do when you are pregnant? Well, first, it's basically how you're eating. I always tell my patients, when you're eating and you're feeling sick, you can't eat big meals. You have to eat tiny meals every hour or 2. When I say tiny, like a bite or 2 every few hours. You never want your stomach to be fully empty, but you also want your stomach to be full. So when you first wake up, you want to try to get something down. Again, nothing heavy, something bland, crackers. But again, and then you want to eat an hour later, another hour later. So that will help. As far as liquids, you want to try and not eat and drink at the same time. If you're going to eat something small, obviously, then you want to try to drink something about a half hour later, and then kind of alternate. That will help. Other things you can do, again, avoid triggers that might make you feel nauseous, whether that's a specific type of food, a smell of a food, smells of in the room. Sometimes stuffy rooms can or very humid rooms can trigger morning sickness. So avoid your triggers. And again, too, also, when you are eating, pick things that you can eat. Again, from a personal experience, my wife, the only thing my wife could eat when she was pregnant was macaroni and cheese and 7-Up. She could eat nothing else. I'm not exactly sure why that was, but that's the only thing she could tolerate. So unfortunately, when you are sick, when you are having morning sickness and pregnancy, a lot of women say, I'm nervous about the nutrients my baby's getting. When you're sick, you kind of have to just kind of figure out what fits best for you, whatever that is, and just stick with it until you get past it. I tell my patients, if you can only eat French fries every day, then listen, eat French fries until you get to a point where you can expand your diet. Other things you can try, very common that people have heard, is ginger, ginger snaps, ginger candy, ginger ale. There's some reason something in ginger can help kind of quell that sickness. Other things you can try, acupuncture, acupressure. I know there are C-bands that a lot of people use for motion sickness. You can buy C-bands at any local pharmacy. There's a pressure point on your wrist that kind of helps. I know for my wife that actually did help a lot. Another thing you can try is hypnosis. That's another alternative. So again, really dietary modification, avoiding triggers, small meals, separate liquids and solids. Again, acupuncture, if it gets to that point, hypnosis, these are all natural remedies that can help. And again, always remember that, for most women, morning sickness will end. I know it's tough in the beginning, but it will resolve.
Okay. Thank you. Really helpful information there. And I have to ask, are your kids now addicted to mac and cheese?
It's funny. I thought my son was going to be born with a Z or a 7 got off across his chest when he was born, but he luckily he was not. But no, for some reason, no, it's just kind of crazy. And now it's kind of funny too. My wife can't stand 7-Up and she can't eat macaroni and cheese.
Oh, wow. That is really funny. But I feel like that's reassuring for people to hear that, it's just whatever it takes to kind of get through the morning sickness and, worry about your diet after as long as you're getting some food in.
Right.
That's good to know. All right. Well, thank you. Okay, Jessica, we'll turn back to you. If you're still having any audio issues, maybe another panelist will take this one on. Yeah. Okay. I think you sound a bit better. Let's go for it.
Okay. I tried to fix it. Okay.
There we go. So a question from the audience: how can someone maximize their chances of getting pregnant while having irregular periods due to PCOS?
Thank you so much, Sarah. PCOS is a hormonal imbalance that can affect many areas of the body in regards to the menstrual cycle, fertility, conception. Some of these symptoms...
I'm going to cut you off. I'm sorry. You're still a little fuzzy. I'm wondering if anyone else can jump in here. I want to make sure everyone can hear this well. Or we can go along and come back to you, Jessica. So sorry.
I can just try and be a little bit louder. Can you hear me now?
Okay, let's go ahead. Yeah.
Okay, I'll yell. Okay, so with PCOS, symptoms of this include excess facial hair, irregular menstrual cycles, or weight gain. If you're having any of these symptoms, you should definitely contact your provider to discuss ruling out this disease. There are many treatments available for you if you do have PCOS to help you conceive. Some things you can do on your own would be to exercise at least 3 times a week and maintain a healthy weight. You can also do things in your diet like eating healthy fats, avoiding alcohol and coffee, avoiding refined carbohydrates like pastries and white bread, eating low sugar fruit like berries, strawberries, and low sugar vegetables, carbohydrate vegetables like broccoli. There are certain supplements that can help: vitamin D, omega-3s, probiotics. But if you are truly diagnosed with PCOS and having difficulty, time is important. So you should address these concerns with your provider.
Okay, thank you so much. Appreciate you raising your voice a little there, but I think we definitely got it. And, something that I'm taking away from this is exercise seems to be important even throughout your pregnancy. So thank you for going through that. Okay, Vicki, we'll turn to you. What options are there for pain management besides an epidural?
Okay, so an epidural is probably the most common or the most well-known option for pain management in labor, but there's a lot of others. Movement, for one, is so beneficial in labor. I mean, it really helps distract and lessen pain with contractions, and it can also help labor progress and lessen the need for interventions or medications to kind of speed up or get labor back on track. Water is another way to help with pain management. Sitting in the shower, using a handheld shower attachment to kind of direct the flow of water to your belly or even your back can help provide some pain relief. Soaking in a tub is another option that can just relieve a lot of pelvic pressure and also the pain with contractions. It also really helps you move in labor, and you can get in different positions that sometimes gravity just doesn't make comfortable. Hypnotherapy or meditation is also common to help kind of cope with labor pain. And this can involve like a commercial program like Hypnobabies or Hypnobirthing, which is a program that has a series of audio tracks that you listen to. It incorporates breathing and meditation techniques. And this is practiced throughout pregnancy to prepare for labor. IV pain medicine is another common option. And this is usually a combination of medications, usually a narcotic or some synthetic alternative that can help dull the pain. It helps the body rest and relax, and it kind of makes you sleepy. It does have some limited effect on the baby, makes the baby sleepy as well. So it's best when it's given early labor or even the middle part of labor. And it usually lasts a couple hours, anywhere from 2 to 4 hours, and makes the pain more tolerable. Another option for pain management, especially if we have back labor, which is contractions that are particularly painful in the lower back, are something called sterile water papules. And this is, these are injections of a tiny amount of sterile water that are placed in 4 spots on the lower back, just right underneath the skin. And they can provide quite a bit of pain release, back pain relief for about 1 to 3 hours. Heat and ice are always nice, depending on where you're feeling the pain or where you're feeling sore, sometimes lower back, sometimes lower belly. Ice on the back of the neck can be helpful. And it can just kind of provide, all your muscles are working so hard in labor, anything that makes them feel better can provide relief.
Okay. Well, thank you so much for going through that. Jessica, we're going to turn it back to you for one more question. So if you don't maybe mind just raising your voice a little bit, gotta love Zoom and all the glory. But one last question for you, I guess going along those lines, what would be the benefits of a natural birth?
Okay, we get this question a lot. Many people say, why would you choose to be in pain? Sometimes I tell people it's similar to why does someone decide to run a marathon? We can't always understand why someone would do this, but the people that do it feel a great sense of pride and accomplishment. You just want to do it and you do it. There is more movement in labor and you can change your positions and move freely. You're able to use hydrotherapy, which is the shower or the tub. You cannot do that when you have an epidural. You also feel more of a natural urge to push your baby out. When you have an epidural, you need more of a direction to push. And then at the end of the day, it's just a personal choice, and we support you in whatever decision you choose, especially if you decide you want an epidural after thinking that you wanted a natural birth. We will always support you in whatever decision that is.
Okay. Thank you. Very helpful. I have run a marathon, so I really appreciate that analogy because I totally get it. Maybe. But okay, Dr. Cavone, let's turn to you. We'll have a question from the audience. Will endometriosis and ovarian cysts affect a pregnancy negatively?
So that's a great question. I'm going to kind of answer in 2 parts. Firstly, let's talk about endometriosis. So what is endometriosis? It's a common term you hear a lot of people talk about. So basically endometriosis is the gland or tissue that's found in the uterus, actually implants outside the uterus. It can be found on ovaries, it can be found on fallopian tubes, it can be found on your bladder, your pelvic walls, it can be found in a variety of places in pelvis, but usually it stays within the pelvis. There are some documented cases of it traveling up into the chest, lungs, but that's very rare. Endometriosis, the most common symptom of endometriosis that we see in patients is pelvic pain, whether it's pain with their cycle or pain with intercourse. We also see it affect the patient's fertility. So a patient that is diagnosed with endometriosis, which again, endometriosis is really only diagnosed from surgical evaluation. However, most patients do not go to surgery for endometriosis. They are diagnosed based on their symptoms and treated based on their symptoms. You know, if a patient does have endometriosis, they are again a higher risk of having pain and high risk of infertility. But if they're lucky enough to become pregnant, endometriosis itself really doesn't cause anything negatively during a pregnancy. In fact, endometriosis actually improves when a patient becomes pregnant. Endometriosis basically feeds off the fluctuation of hormones during a woman's menstrual cycle. And when you're pregnant, the hormones they do skyrocket when you first become pregnant, but they eventually kind of plateau and level off. And because of this, patients that have endometriosis pain before getting pregnant actually find to have significant relief to their pelvic pain when they actually are pregnant. So for the most part, there isn't really any negative side effects of endometriosis to the pregnancy. But again, I say for the most part. So there are some potential risks when you have endometriosis. Now, and again, I want to stress this these risks are very, very rare in a patient. So I don't want if a woman that has endometriosis, I don't want them to fear that these risks I'm just about to talk about are going to happen to them. Again, these are very risks, but I think it's important to know that there are some slight risks if a patient is diagnosed with endometriosis and then becomes pregnant. And those risks are, preterm delivery, potential miscarriage, a placenta previa. A placenta previa is where the placenta implants in the lower part of the uterus versus being in the upper part of the uterus. And the placenta previa can sometimes end up, a patient needs a C-section because of the low location of a placenta. Preeclampsia is another potential risk factor, and Dr. Ahmad mentioned that in a previous question. Preeclampsia is having high blood pressure in pregnancy. So again, endometriosis for the most part, as far as pregnancy, is a benign condition, but there are some slight risks to it. Now, the second part of the question, ovarian cysts. So ovarian cysts are very common. I try to explain to patients that ovarian cysts are basically like little water balloons that are found in your ovaries. They're there for a purpose. Most of them are physiologic. Women make cysts every month as part of their ovulation. And for the most part, ovarian cysts usually do not cause any complications during pregnancy. A lot of times ovarian cysts are found when a patient comes in for their initial ultrasound. And during the initial ultrasound, they'll obviously ultrasound the uterus and for the pregnancy, but they also look at the ovaries and fallopian tubes and make sure there's no pathology outside that. So it's not uncommon for a patient to leave her first initial ultrasound and be told, oh, you have a cyst on your left ovary or a cyst on your right ovary. Again, for the most part, ovarian cysts are benign findings that don't really cause any complications during a pregnancy. It's something that we just kind of follow as you get your ultrasounds through your pregnancy. However, they can be symptomatic. During a pregnancy, ovarian cysts can cause pain. Again, and this pain is not dangerous, but it can be annoying for patients. You can take Tylenol for it. Heating pad is very good to kind of deal with ovarian cyst pain. Now, there are a couple small little risks to ovarian cysts that could be a little more that could be more pathologic, where a pain could be worse. So, if a patient experiences ovarian cyst pain that's not getting better by Tylenol heating pad, it could be because the cyst ruptured, or because the ovary tores on itself, and torsing means it actually twisted on itself because of the cyst being present. Now, a ruptured ovarian cyst, again, can be painful, but again, that's usually self-limiting, where nothing has to be done about that. However, there are some ovarian cysts where when the cyst ruptured, it causes a little bit of bleeding from the ovary. And that potentially, if the pain is progressively getting worse and not improving, could potentially be a surgical emergency and need surgical intervention. And there are pregnant patients who have needed surgery for their ovarian cysts, not because of a potential torsion or potential cyst. But again, overall, ovarian cysts are most of the time benign. They're physiologic, again, and usually they don't cause any symptoms to any patients during their pregnancy. So,
okay, thank you. Some really great information there. Appreciate you walking through that. Okay, Jessica, one other question for you with a bit of personal scenario here, if you don't mind speaking up again.
No,
But thank you. So why do we have to wait so long to have our first appointment? And maybe I just found out early and another 8 weeks seems kind of long.
this is a great question. The main reason why we wait until the 7 to 8 week period is because we cannot see your baby on ultrasound usually until this point. So if you do not have any symptoms, like some of the symptoms Dr. Hummel talked about earlier, you're going to assume that your pregnancy is normal because you've probably taken a home pregnancy test to confirm the pregnancy that way. If you have a history of high-risk pregnancies, if you have any symptoms that just do not feel normal to you, that is definitely an indication to be seen sooner. If you are having a difficult time getting into the office, we offer telehealth visits as well. We really want to make sure everyone feels supported in getting the care that they need. Or you can also have an earlier visit, but know that we generally cannot do much more than a urine pregnancy test to give you any more information because we cannot see the baby, we do not see the heartbeat until this further point.
Okay, thank you so much. Dr. Hummel, let's go ahead and turn to you. Should someone schedule a preconception visit?
So a preconception visit isn't necessary for every patient, but we do welcome any patient who wants to get more information about planning their pregnancy. And it's very easy to schedule a preconception visit. It can either be done in the office or it can be done via telehealth, like Jess mentioned earlier. It's definitely important in patients who have a significant medical history so that we can discuss their medical history in terms of any effects on the pregnancy. It's important in patients who have a family history, especially of any metabolic or genetic abnormalities, like Dr. Caffeine mentioned earlier. Patients who are on long-term medicines that maybe they shouldn't be on during pregnancy, or they aren't able to stop them from one reason or another, but still want to expand their family. We can talk about the safety of medications in pregnancy. And like Dr. Caffeine mentioned earlier, we do have the ability to screen for genetic conditions that can be passed down from parents to children, such as cystic fibrosis, spinal muscular atrophy, hemoglobinopathies, Fragile X, Duchenne muscular dystrophy. And there are also some conditions that do have higher prevalence in some ethnicities, such as Ashkenazi Jewish patients. So again, many of these carrier conditions can be screened by just one blood draw. And having the knowledge of whether or not you're a carrier before you enter into a pregnancy can be priceless information. And if you are found to be a carrier, there are options, like Dr. Caffeine mentioned, like IVF, and they can actually sample the embryos to test for genetics before they actually implant that embryo back into your uterus. And this can then help you proceed with a pregnancy of a baby that would be unaffected by that condition. Otherwise, during a preconception visit, we can discuss the most fertile times so that you know when you can conceive. Again, your medical history and prior pregnancy history. Did you have preeclampsia in prior pregnancies? What can be done in this pregnancy to help prevent that? Did you have diabetes in prior pregnancies? Did you have a C-section and want to talk about maybe having a vaginal delivery this time? And if you're getting irregular cycles and don't know when you can get pregnant, we could talk about how we can try and help you figure out when you're ovulating. And then we can also talk about how long you should be trying before you need to take the next step in conceiving if you're not able to conceive on your own, whether we talk about medications, labs, or other testing.
Okay, thanks so much. Vicki, let's turn to you as we've been receiving a lot of great questions. So in just a bit, we'll also go to our live audience questions. Okay, question for you. Can you talk about the best ways or way to go about a birth plan?
So a birth plan is exactly what it sounds like. It's the plan that you have for your birth and what you ideally want to see happen to give you the best experience possible. These birth plans can be as simple as just talking to the provider at the office and kind of discussing what is important to you and what's not important to you. Or it can be as detailed as, a 5-page document that you print out and you bring with you to the office and to the hospital. The biggest thing is just to discuss it. Most of the elements that are in common birth plans are pretty much standard in the hospital now. Skin to skin contact with the baby after the baby is born, delayed cord clamping, delaying newborn baths, avoiding episiotomies, things like that are very standard and the norm for most hospitals. The biggest reason to have a birth plan and the biggest benefit is just the education and research that goes behind formulating your birth plan. Some people didn't know about delayed cord clamping. And as they're researching this birth plan, they're like, oh, what is that? And it causes them to look further into it. And then the discussion that follows, that research and the questions about each component, the back and forth between provider and the patient, and the shared decision making on, what's important and the rationale for different interventions. Some of the preferences that people like to include on their birth plans are details about support people, who they want there with them, who they don't want with them, the type of pain management that they want, how they would like to feed their child, different interventions that they want to have, like an epidural, or if they choose to have an induction of labor. Also things that they absolutely don't want, if they want to avoid a labor induction, or they want to avoid, unnecessary interventions, like episiotomies or frequent vaginal exams, things like that, that they want to be avoid. That being said, the best plan for birth is just to be open. There's so many variables in labor, and plans might need to change. So yes, the birth plan is our ideal situation, and as close as we can, keep the path to that, the better. But yeah, being flexible is also a key to a great birth experience.
Okay, thank you. Yeah, I think that's a great point of balancing being prepared where you can and answering those questions. But then, as you said, being flexible sounds definitely important as well. So thank you for detailing that. All right, Dr. Hummel, a question for you that we've definitely been receiving from a number of people. How can someone assess infertility in oneself and their partner? Additionally, if a menstrual cycle is regular, what can cause infertility in women 35 or older?
This is a great question. It's something we hear multiple times a week, I would say, in the office. Patients have been trying for a bit of time, and like, why can't I get pregnant? It's not always as easy as, trying the very first month, or conceiving the very first month you start trying. So we don't consider someone having a problem conceiving until they're actively trying for 1 year. If they're younger than 35, or if they're 35 or older, you get a window of 6 months. So if you haven't conceived in that period of time, then it's time to investigate and see if we can figure out why. So the easiest part of the workup is a semen analysis. And this can be easily done through a fertility specialist or through a urologist, where the male partner will ejaculate into a cup, and then they look under the microscope and literally look for the number of sperm, how they swim, their shape, all things that can play a role in the ability for that sperm to be able to get to and then to penetrate an egg. So that's fairly an easy test that can be done. In terms of the female and her workup, we would do blood work on day 3 of their menstrual cycle. And this will look at what we call the ovarian reserve, which is the reproductive potential that's left within a woman's ovaries based on the number and the quality of eggs. The quality of a woman's eggs does decrease with each year, especially after the age of 35, but that doesn't mean that you can't have a very healthy, genetically normal pregnancy after 35. Another test we could do is a pelvic ultrasound, and this would help us look for any structural abnormalities that may cause problems getting pregnant, such as large fibroids that might be blocking the fallopian tubes, or a malformation of the uterus that a woman may be born with and never knew they had until we start looking for things like that. Any prior history of a pelvic infection, like pelvic inflammatory disease, that's often caused by sexually transmitted diseases such as chlamydia or gonorrhea, that can block the tubes, which would then prevent the sperm and egg from meeting. So that could be a problem that would need to be evaluated. And also, like Dr. Caffeine mentioned earlier about endometriosis, that can also cause damage to the fallopian tubes, or any history of a prior ectopic pregnancies. So in order to evaluate that, there's a test that's done in radiology called a hysterosalpingogram. We inject some dye in the uterus and watch it go out the fallopian tubes to show that the fallopian tubes are open so that the egg and the sperm can actually meet. So that is a fairly simple procedure that can be done as well. In terms of women over 35, they are considered what we call advanced maternal age, and then actually men over 50, so they don't get out of it either. But with these patients, there's an increased risk of genetic abnormalities due, again, to the decreased quality of eggs and sperm as we age. So in any woman, poor ovulation may also lead to trouble conceiving, and we usually see this with irregular menstrual cycles, especially in patients with things like PCOS. But there are medications that can help with that. So we would want to rule all of those things out with those tests.
Okay, thank you so much. I think that really detailed a lot of questions that people are having tonight. So appreciate that. Dr. Covone, we'll turn to you. What could be expected from the labor and delivery department in terms of facilities and other accommodations?
Thanks, Sarah. It's another great question. So obviously, all patients want to go to a place that they're going to feel comfortable with, feel well cared for. So a couple of things you want to look out for when you're, when you're looking for a delivering hospital. Number one, the room. I would make sure that all rooms are private. Their labor room should be private, as well as their postpartum room, which is the room they move to after delivery. What type of rooms they are offered there? Are they low risk birthing suites? Are they high risk birthing suites? At Jefferson, we will be offering low risk birthing suites coming up in the next year, which we're excited about. And with those birthing suites, which brings my next point, is what kinds of things does a hospital offer as far as pain management? I know we talked about natural forms of pain management, but does your hospital allow you to be mobile during your labor if you're not on any kind of induction medication or you do not have an epidural? Does your hospital allow you to sit in a chair, use a birthing ball, sit in a tub, which again, these are things that Jefferson, New Jersey does offer to all our patients. Does your hospital allow intermittent monitoring? Again, for the women who wants to go through a more natural childbirth and not being induced, are they allowed to move around and be monitored once in a while versus being strapped to a bed and unmonitored? So again, something that, again, we also offer here at Jefferson, New Jersey. What else to look out for? You want to know your care team. You want to know how your care team's set up. Are there students involved in your care? Are there residents involved in your care? Are midwives involved in your care? Are and attending physicians? And then not only who's involved with your care team, it's where are they? Here at Jefferson, New Jersey, our system is that our providers are in-house, which means our midwives are in-house with us, and our attendings are in-house, which means that when you come into labor, we're already here. We're not being called from home. We're not being waking up from our bed that's our house that's a half hour away. We're here before you get here. So, which is beneficial because God forbid there's an emergency, we're already here to take care of it, and there's no waiting around. On that same topic, from an anesthesia standpoint, for the women who do want epidurals during their labor, is anesthesia in-house or are they being called from home? Again, Jefferson, New Jersey, our anesthesiologists are in-house. They're there for our patients for their pain management and also for any kind of obstetrical emergencies so that we can take care of emergencies very quickly. So another thing to look out for is the level of care for a NICU, if your hospital even has a NICU. Again, here we have a level 3 NICU, which is housed by our neonatologists 24 hours a day, 7 days a week. That's important. Our neonatologists are there to attend any high-risk deliveries. They're there to attend all our C-sections. Having a level 3 NICU also means that we can handle babies from 24 weeks, which is basically at viability, to full term, which is good because, again, we don't really have to transfer any of our patients outside of Jefferson, New Jersey. And to that next point, are you delivering at a hospital that is low risk? That only handles babies over 32 weeks or only handles babies over 36 weeks. If that's the case, what is the transferring hospital? You should know prior to going to the hospital, where is your baby going to be transferred, or where are you going to be transferred if you're considered high risk and can't deliver at that particular hospital? Again, here, having a level 3 NICU and being able to deliver babies between 24 weeks to full term and having them cared for our NICU if NICU is necessary, we don't need to really transfer anybody out unless the baby needs post-delivery surgery. Then that baby would have to be transferred out. For most hospitals in the area, that's common. There's only really one hospital in the area that does neonatal surgery, and that's either CHOP or DuPont down in Delaware. So what else to look out for as far as accommodations? Is there a high-risk medicine surgery, which is called maternal fetal medicine? Are they available for consultation just in case you get a high-risk patient does show up? What else? Visitor policy. It's important to know what the visitor policy of labor and delivery is and postpartum. How many patients can be in your labor? How many cannot be in labor? Who do you want there? Who don't want there? Here, due to COVID, we've luckily, because our numbers have gone down, our level is now gone to green, which means that we're allowed to have 2 visitors for each patient. And if you're going to have a doula, then you have 3. So it's important to know your visitor policy as well on your floor. What else? Does the facility have a nursery? Here at Jefferson, New Jersey, we practice rooming in, which means we do not have nursery here. We keep our babies with our moms, which I think is very important as far as bonding. So that's a very important aspect of your delivery and your postpartum care. Does your facility offer or should encourage breastfeeding? Here we have a lot of support for our breastfeeding moms, our midwives, our physicians, our nursing staff. We also offer lactation consultants during your hospital stay as well as when you get discharged. So it's important to know what kind of breastfeeding support system is around your hospital. And if you choose that you don't want to breastfeed and want to formula feed, ask the question, what type of formula is offered at your hospital? So you can do some research about that. Other things, does your hospital offer tours? Do they offer childbirthing classes, which we do? Tours, that was kind of put on hold because of COVID, but we have childbirthing classes that we do offer through our practices. Another thing, eating, can you access food during your labor? Obviously, when patients are in labor, they might not be eating, but after they eat, most patients are starving. So how can they access food? Is there cafeteria open? What kind of cafeteria do they have? Are they allowed to order outside the hospital? Can their partner be sent to, seems like a Wawa hoagie is always a big selling point for women. As soon as they deliver, they want a Wawa hoagie. Wawa hoagie or sushi, that's the 2 big selling points. So these are all important aspects that you want to know about about the facility you're going to be delivering at. So.
Okay, thank you. Wawa hoagie, that sounds good to me. But very important questions to consider. I think it can be easy to think totally about the pregnancy, but also facilities is important to think about. So thanks for going through that. Okay, so we certainly are receiving a lot more live questions. Thank you so much for your engagement tonight. But before we go into that, I'd like to ask each of you, what are your goals for patients and potential patients on this webinar? What do you want our viewers to take away from tonight? So Dr. Cavone, we'll go right back to you. Feel free to share your sentiments here.
So I guess the biggest thing I would want to say is that, women's reproductive health is extremely important. That's why we entered into the specialty. The physicians, the midwives. This is why we do it, because we know how important a patient's reproductive health is from when they first get their period until menopause and beyond. So it's we feel pride and we're honored that we have the ability to take care of women and take care of their needs. The other important thing, which I think is crazily important, is that ask questions. People are always afraid to ask questions. They don't want to sound not smart or afraid to ask a question. This is your health. This is whether it's a menstrual question, a pregnancy question, a menopausal question. Don't ever be afraid to ask a question. The worst question out there is the one that's not asked. We're there to support our patients and to be there for them. And there's never a question that's silly for anybody. So that's my most important. Ask questions.
All right, thank you. And clearly we like to answer questions, right? Because that's what we're doing here tonight. Okay, Jessica, let's go ahead to you.
I guess my 2 take-home points with this topic tonight is that there are many different ways to approach your health and fertility. And we have a variety of providers who can provide, safe, supported, respectful care depending on what your needs are. Fertility and conception do not always follow the rules of science. And I would just want patients to have an open mind and be open to changes in their plans and, changes to what they expected. And know that we are here to support you and we will do everything we can to help you achieve your goals.
Okay. Thank you so much. And Vicki, what would you like viewers to take away from tonight?
I think the biggest thing is that your health care should be an interactive experience for everybody. You should be the most important member of your healthcare team. The needs of your family are different from everybody else's, and our role as providers is to kind of give you all of the information. We take the clinical picture, we summarize what the options are, and we kind of help you, we give recommendations and we help you decide what options are best for you, because it's going to look different for every individual person. and who's going to know what is best for you more than you?
Absolutely. Okay, and Dr. Hummel, to finish us out.
Sarah, it's really hard to go last. I echo all of my colleagues' sentiments. Just know that we are here through all stages of your reproductive and post-reproductive lives, and we are just an office visit or a phone call away.
Okay, perfect. Well, we're going to stay on and just answer a few live questions that we've been receiving. So let's go ahead and get started. Anyone is feel free to chime in as I read aloud. But our first question from the audience: how should you manage your calories to ensure you're getting enough if you have a very active lifestyle? For example, working out every day. Should you engage a nutritionist if you feel like you're very active? And anyone feel free to answer that.
I can answer that. If you are concerned about your nutrition, if you have any special nutritional needs, it's always the best thing to meet with a nutritionist and kind of go over what your lifestyle looks like, how your activity, how many calories you're burning a day. So how many do you need to replace? There are extra calories that are needed in pregnancy to help grow a baby, and proteins and fats and all of the macros are very important. And if you burn more than the average person, you're going to need more than the average person. So a nutritionist or a nutrition consult is never a bad idea.
Okay. And Vicki, I'm going to ask you another question. We've been receiving a few diet questions tonight. So what would be the best diet when trying to conceive? Is it okay to do the ketogenic diet? Additionally, are coffee and Diet Coke okay during pregnancy?
In general, it's coffee. That's an easy answer. About 2 servings of caffeine are, considered safe during pregnancy, or safer, which equals about 2 cups of coffee to, regular 8 to 10 ounce cups of coffee. So that's acceptable. And a lot of times with the common discomforts of headaches, that can definitely help. Or, I'm sorry, what was the other question?
Oh, let's see. The ketogenic
Diet Coke.
Oh, and Diet
Diet
Coke.
Coke.
Yes.
Yeah.
Yeah.
I would say avoid Diet Coke just because of the artificial sweetener, but that might be a personal choice.
Okay. All right. Well, thank you. I think we just got a sigh of relief for the coffee. And then I guess just ketogenic diet. Do you have anything to add about that?
The keto diet has lots of protein, so it's great. People tend to avoid a lot of the simple carbs that aren't that great for us anyway. So I'd consult with a nutritionist.
Yeah, like to truly be in a ketogenic diet and putting your body into ketogenesis while pregnant, I wouldn't probably recommend, because we need to not necessarily be doing that in pregnancy. So once again, maybe a nutritionist, but you do need the carbs and the other things to have normal function. So ketogenic diet isn't always the best option inside pregnancy.
Okay. Thank you so much. All right, let's go ahead to the next question. What are the best practices for tracking ovulation at home? And if anyone has any, go ahead, Dr. Hummel.
I can take this one. So at the time of ovulation, you get a very small spike in your basal body temperature. And it's not the easiest thing to track, but you would need a thermometer that goes into a couple hundredths of degrees, because it can be that small. As soon as you wake up in the morning, before you even lift your head up off the pillow, you would check your temperature, and then you would track it. And when you see that small spike in temperature, that would be the time of ovulation, or the time that you're most fertile. The other thing you can do is, I know it's going to sound gross, but you can actually kind of investigate your cervical mucus. So cervical mucus at the time of ovulation is very kind of sticky and stretchy. So thanks, Jess. So you could literally kind of investigate your cervical mucus to see if once it hits that kind of that texture. But typically, if you are getting regular menstrual cycles, then we kind of know when you ovulate. We all have seen those apps that are out to track your menstrual cycle. It actually gives you a window of when you're most fertile. So we all kind of ovulate at the same time in the cycle. So it's just knowing, are you a 28-day cycler? Are you a 30-day cycler? And when that window of, high fertility occurs. So, the tricky part is if you're not getting regular menstrual cycles, kind of how do you track your ovulation? And then it's more the, the basal body temperature. They sell a little, like, looks like a urine stick, ovulation predictor kits that you can literally urinate on, and you'll get a little smiley face when you're ovulating. So those are the things that you can do. But it's kind of easy to track when you have regular cycles.
Okay, great. Thank you. Another follow-up question. Any recommendations for a former bariatric surgery patient trying to conceive, or maybe recommendations just overall during pregnancy? And whoever wants to take that one, feel free.
So I can take some of this.
Mhm.
And this may be a discussion, this would definitely be a discussion to have with the bariatric surgeon, maybe even before you go in for that type of surgery. But I believe they recommend waiting 18 months after the surgery before you try to conceive. So if you are planning that surgery and still planning a family, an expansion in your family, you want to kind of keep that in mind. But otherwise, we want to make sure that you're eating healthy in pregnancy, always have something in your stomach. You're not going to want to eat big meals while you're pregnant anyway. So those smaller meals will be helpful. When you do your glucose screening in pregnancy, you may not be able to tolerate that big drink that you drink to check your sugar an hour later. So there are things that we can do, like check your blood sugars with a glucometer to watch your blood sugars instead of doing that test. But otherwise, eat healthy, make sure that you're getting a good prenatal vitamin, and hopefully your body will be absorbing a lot of the nutrients that it needs for the pregnancy.
Okay, great. Thank you.
Also, to add to what Jen said, which is very important, sometimes we'll actually draw blood on our bariatric patients when they come in for the initial, just to see what their vitamin levels are, to make sure there isn't any vitamin deficiency due to their surgery. So, but everything Dr. Hummel said was right on the spot.
Okay, perfect. Thank you both. We've received just a few questions about birth control. So I'll start with our first one. If taking birth control, when is the appropriate time to stop before trying to conceive?
I can take this one too. My recommendation is to wait 2 natural menstrual cycles after you stop the birth control to conceive. When you're on birth control, that lining of the uterus is very, very thin, and we like a nice, fluffy, thick lining for an embryo to implant on. So once you stop it, ideally wait until not the following period, but the period after that to start trying.
Okay,
And
perfect.
also remember to start your prenatal vitamin before you go off of birth control.
Yes, good point. Thanks, Jess.
Thank you for the reminder. Awesome. And follow-up question to that, how long should I give my body to go back to my normal cycle after stopping birth control before trying to conceive?
It will happen instantaneously, depending on what birth control you're on. So the birth control pill, the patch, the NuvaRing, the IUD, your fertility cycle will start instantaneously. The Depo-Provera shot is the one where it could take a little bit for your natural cycles to start back up. It may take up to a year to get a period back. But that's the only tricky one. The rest you can conceive as soon as you stop the birth control.
Okay, thank you. Another question that just came in, what can women with fibroids do to have a better chance of conceiving?
So I can answer that. So really, to answer that question, you have to know what type of fibroids you have and exactly where are they and how big are they. And that can be diagnosed via ultrasound or even MRI. And then based on that, a conversation with your provider to determine if surgical intervention is necessary. I mean, really the only true treatment for fibroids as far as a fertility standpoint would be surgical intervention. And that could be done either through an open procedure or like a C-section procedure where we make an incision and go in and actually take the fibroids out, or it also can be done laparoscopically or minimally invasive. Probably the risk that we worry about when we do fibroid surgery is, causing any damage to the uterus, which could make fertility after the surgery a little more difficult. And then you worry about, based on your surgery, if you do get pregnant, based on surgery, are you able to deliver vaginally after that procedure, or do you need a C-section? That depends on how invasive you are from your surgical standpoint, and how invasive the fibroids were.
Okay, great. And Dr. Bone, through that answer, you answered another question we got about fibroids. So thank you. All right. Another question that came through. Both of my sisters had miscarriages. Should I be concerned?
So miscarriages don't run in families. So even if your sisters had miscarriages, doesn't mean you ever will. However, if you were to have miscarriages as well, it would definitely be worth screening for any type of genetic conditions that you may have. You may be physically fine and normal, but you could pass an abnormality onto an embryo that could make that pregnancy at an increased risk of a miscarriage and a loss. So if you are having recurrent losses, then it warrants more of an investigation to figure out why.
Okay, thank you. All right, next question that just came in. Is there a good resource to find a doula in the area? What should you look for in a doula, licenses, etc.? And whoever wants to take it.
So I would say the DONA website, so Doulas of North America, is a great source to find doulas in your area. Most often they are certified, meaning that they have gone through courses to really expand their skills, and they've taken tests to certify them. So the DONA website is a great source. And then just word of mouth, some Facebook groups, mom groups in the area, things like that are a good place to look as well.
Great. Yeah, word of mouth is always a great option. So thank you. Okay, Jessica, question for you. As I know you were talking about prenatals earlier, an audience member would like to know, is there a particular prenatal vitamin you recommend, and does it vary from patient to patient?
Well, some people's insurances will cover certain prenatal vitamins. So we always, like to have that work out for you. So if your insurance covers prenatal vitamins, you can let us know the specific brand. There's so many options out there. Some may have more iron. If you have a history of anemia, there's certain ones that are vegan, if that's the type of diet that you follow. There are a lot of women who can't tolerate swallowing the pills, so we recommend gummies. I know that I personally use the gummies Smarty Pants. They tend to have a lot of good natural options in there, and it basically is easier to digest because it is a gummy vitamin. There's a lot of options, so it's really hard to give one. It's a personal preference, and if you have one that you don't like and it makes you nauseous, please don't stop taking them altogether. Just try another brand and keep trying, and you'll find one.
Okay, so good to know you have options. Thank you. Okay, a question about water birth. Can a water birth occur at the hospital or at home only? And relatedly, do I need to include a tub birth in my birth plan, or can I decide during labor?
This is a good question. We are currently in plans for tubs here at Jefferson, New Jersey. I don't have the answer as to whether or not we will be planning birth in the tubs, but we most definitely will be doing what's called hydrotherapy. So we will be for sure having women in the tubs, and you can always decide last minute that you want something like that. Doesn't have to be planned ahead, but water births do happen in hospitals. So to answer that question, you do not have to have a home birth to have a water birth, but stay tuned for the future of our tubs.
Okay, we'll stay tuned. Sounds good. Okay, another question, and this is about running. So now we talked a little bit about exercise before, but specifically about the distance. So what distance of running is too much for a new pregnancy? I have a half marathon plan that I've been training for, but am terrified I will hurt the baby.
Yeah, sorry, Vicky. I saw you unmute yourself. So you can just add to mine. So there is no such thing as too far or too short of a run. I had a patient who complained to me at 37 weeks that she was only able to run 8 miles now at the end of her pregnancy. So ridiculous for those marathon runners. But there's no such thing. Just, as your belly gets bigger, it may start getting uncomfortable. So I would recommend like a belly band or something to support your abdomen while you're running. And then, just be aware of, your heart rate, make sure it doesn't go too high, make sure we're oxygenating the placenta well. But otherwise there's no rules.
Okay, really good to know. And I guess a follow-up question to that too is weightlifting okay?
So I do have to say, I've had pregnant people who power lifted their entire pregnancy because that is something that they were just really, they've done it for quite a while. It's nothing you want to start new, obviously. And the biggest thing is just any kind of type of activity. Listen to your body. It's going to tell you if something's too much, if it's too heavy, if the movement is too strenuous for you. So as long as it's a normal, uncomplicated pregnancy, there's really no limits. Kind of like the same with running, listen to your body.
Perfect. Love it. I think that's great to know. Listen to your body. I like that message. Okay. Can you talk about, whoever wants to speak to this, elective C-sections and maybe discuss the pros and cons?
Dr. Cabone, I think this is yours.
So it's a difficult question because us as providers, obviously our goal is to push for our patients to have vaginal deliveries. And again, so why do we push for vaginal versus C-section? So what are the cons of having a C-section? Number one, recovery. A vaginal delivery, I tell patients that when they go home, they can kind of do whatever they want after they've done a vaginal delivery. A C-section, you're talking about a 4 to 6 week recovery, even potentially 8-week recovery time. So again, after a C-section, you going home to take care of a newborn and try to recover from a C-section can be very difficult. That's number one. And again, what people seem to forget when it comes to C-section, a C-section is a major abdominal surgery. Yes, it's a very common surgery that's done in the United States, but it's still a surgery and it's still a major abdominal surgery where we are, and forgive my being graphic, but we are cutting through multiple layers of a patient to get to the uterus, including cutting the uterus to get the baby out. So there are inherent risks for a major abdominal surgery. What are those risks? There's risks of causing an infection. There's risks of causing a blood clot. There's a risk of bleeding after the C-section, whether it's during the C-section or what we call a postpartum hemorrhage, which is after delivery. There are risks of injuring organs that we're not supposed to injure. Some women might not know that your bladder and your uterus are basically, they are stuck right on top of each other. That's how who we want to believe, that's how you were built. There's always a risk of causing a bladder injury during a C-section. Even if it's your first C-section, there's a risk. There's a risk of causing bowel injury. There's a risk of causing blood vessel injury. So next, and having a C-section, even though, again, as providers, we encourage our patients who did end up having a C-section with their first pregnancy to attempt a vaginal delivery after a C-section. You are still at risk for having subsequent C-sections and the risks that come with having multiple C-sections. And what are those? Same things I just said, including infection, bleeding, damage to surrounding organs. Another risk of having multiple C-sections is a thing called the placenta accreta, where the placenta actually will adhere up into the uterine scar. And with that, the placenta will not come out on its own after delivery. And women can have severe bleeding where they end up actually losing their uterus after the C-section. So as you can see, I've talked about a lot of cons for elective C-section. As far as pros, I don't really have a lot to say. My colleagues can interject and add. The only pro, the thought of, knowing when you're going to have your baby at a scheduled time, I guess, but again, I know there's women that will say, you know, I don't want to labor. I don't want to push my baby out. I don't want to go through the pain. You know, to us, that's not a true reason to move forward with a C-section. You know, obviously we have done elective C-section patient, not from request, but based on other medical conditions where we were told by other providers based on a neurological concern or a cardiac concern or a orthopedic concern that a mom needed an elective C-section because she would not be able to push her baby out. But without having a medical condition where we felt elective C-section was necessary, we really try to prevent it. In fact, that's one of our qualities in our hospital is to decrease our C-section rate, because we know as providers, the cons of having it, and also from the mental standpoint, you know, there's good literature out there that women that end up at a C-section have a high risk of potential postpartum depression. Again, from the recovery of a C-section and having to take care of their newborn baby and dealing with the recovery from C-section. So to us, so obviously, you know, there's a lot more cons than there are pros.
Okay. Thank you so much for walking us through that. And go ahead, Jessica, if you wanted to add anything on there.
I was just going to say that Jefferson, New Jersey, in the state of New Jersey, is one of the hospitals with some of the lower C-section rates. And I think that's evidenced by the care that we give. And we really encourage women to try a vaginal as much as possible. So just to go back to what Dr. Cabone was saying.
Terrific. Thank you. Okay, we have one last question before we finish up the evening, but thank you again to all of our participants, because these questions have just been terrific, and I know I've learned a lot tonight, so thank you. Okay, our last question for this evening, what are some good resources for spouses to support you throughout your pregnancy?
So there's a ton of resources. There really are, but the only thing that definitely comes to mind is, and it's an older book, but it's called The Birth Partner, and it's specifically for supporting a pregnant person. But if you look at the different websites, the ACNM, the midwifery website, has handouts specifically for partners. And I wish I had more on the top of my head, but yeah, that The Birth Partner is a great book.
Okay, I think that's a terrific starting point, so thank you. All right, well, I think we're about done for this evening. So I want to give an opportunity for any final comments. Dr. Cabone, how about let's start with you?
I just want to thank everybody for joining. I want to thank Sarah for hosting. I want to thank my colleagues for doing a terrific job in answering everyone's questions. I really hope everyone learned something about, the bump, and then before the bump. I hope we learned a little bit about Jefferson, New Jersey, and what we can offer as a team. As you can see, we're made up of a pretty great team. I love working with everybody on this phone call, with this webinar, excuse me. So yeah, I hope, like I said, most importantly, I hope you guys learned something, and good luck to everyone.
Okay, thank you. And Jessica, we'll go to you.
Once again, thank you to everyone. I just want to say that I feel that Jefferson, New Jersey has a really great mixture of what people can find from very low risk to the very high risk. So please know that coming into this practice and hospital, you can have all sorts of care and be supported in your care in whatever you choose to do.
Okay, thank you. And a special shout out for talking a little louder tonight with the Zoom mishap. So we appreciate it. Okay, and Vicki. Oh, yes.
Again, I just want to thank everybody for coming. It's really been great to kind of talk through these things and answer some questions and biggest takeaways, ask questions, lots of questions, and listen to your body. That's all.
Love it. And Dr. Hummel, but last but not least.
Yeah, just again, thank you all for joining tonight. Thank you, Sarah, and for my partners. It was very informative. I even learned some things today. So it's been wonderful. Just, know that we are happy to help, and we definitely look forward to seeing you in the office.
Okay, thank you. And I think if you learned something, that's saying something. So a great educational evening for sure. Well, thank you again, Dr. Cavone, Jessica, Dr. Hummel, and Vicki for your time this evening. As we close out this evening, we will be posting a website link that Jefferson is continuously updating with the latest information about the pandemic. We will also be posting a post-event survey so you can let us know your thoughts. Was this helpful? Is there another time that works better? Any other specialties that you would like to hear from? Your feedback will certainly help us bring more virtual events like this to you, the patients. And if there is anything anyone here at Jefferson can do for you in this time of need, please reach out to us. We will continue to offer the wellness webinar series events. So please go ahead and keep checking jeffersonhealth.org for those upcoming patient events. And we have webinars coming up over the next few weeks. So on this screen, you can visit the URLs to find out more information about the events, register, and submit your questions to the panel of physicians. And a recording of this event will be sent to you so you can rewatch. Thank you once again for joining us, and please be sure to stay safe and healthy. Thank you all.